Hello, everyone, and welcome to our roundtable, Autopsy's Role in Pathology Training. This virtual event has been organized by The Pathologist. My name is Michael Schubert, editor of The Pathologist, and I'm joined by an esteemed panel of experts, including Maximilian Buja, Distinguished Teaching Professor at McGovern Medical School at the University of Texas Health Sciences Center at Houston, Michael J. Klein, Pathologist-in-Chief Emeritus at the Hospital for Special Surgery and Professor of Pathology and Laboratory Medicine at Weill Cornell Medical College, Jelena Marks, Senior Medical Examiner at the Office of the Chief Medical Examiner in New York City, and Alex K. Williamson, Chief of Autopsy Pathology and Director of Northwell Regional Autopsy Service, Pediatric Pathologist at Cohen Children's Medical Center Northwell, and Associate Professor of Pathology at Zucker School of Medicine at Hofstra Northwell. So, without further ado, let's get started. Can I get you to tell us a little bit about yourselves and your backgrounds in autopsy and education? Why don't we start with you, Max?
Very good, Michael. Thank you very much for this opportunity. I am a graduate of Tulane Medical School, and during that period of time, I got involved in doing work in the area of cardiovascular disease. I was able to go to the NIH to further my training and became a cardiovascular pathologist. Now, there's a link between cardiovascular disease and autopsy because many patients with cardiovascular disease have serious illness and frequently may have sudden death. So I became very interested in the autopsy, forensic aspects, as well as hospital-based autopsy. And I have also found that combining autopsy pathology with an interest in academia and scholarship made a very good blend for me. So that's what I've pursued over the years.
Great, thank you. And Alex?
Thank you again for organizing this roundtable, and thank you to my colleagues for engaging in this. I basically am based in the hospital setting. I run a large regional autopsy service covering about 22 hospitals. I also am trained in and practice forensic pathology as a per diem medical examiner now, but I trained in New York City. So I kind of straddle the world between hospital and forensic pathology and autopsy. I'm also a pediatric pathologist, which, similar to the cardiovascular realm, has a natural segue into post-mortem examination, particularly in the perinatal setting with fetuses and neonates. I benefited from having two great mentors in my residency, a pediatric pathologist and our chair, Dr. Pepkowitz and Dr. Geller. And from day one of residency, I became fascinated with the realm of post-mortem care, autopsy pathology. Today, that's about 80% of my practice is autopsy. I teach learners of all levels, medical students at our school, residents, fellows. We also have an active engagement of my clinical colleagues around Northwell. And one of the most rewarding aspects, I think, of autopsy is the postmortem care we deliver to the families. And that's something that I've really, in my 10 years of practice, have come to really appreciate and enjoy for what it is meeting with the families of a decedent and reviewing with the clinician their clinical course, what we found at autopsy, and then putting it into context for them. And I find that the way that helps them understand their loss, maybe process their grieving, and helps us as a health system kind of move forward with the knowledge gained from that experience. I find that to be incredibly rewarding.
Thank you. Jelena, how about you?
Hello, everybody, and thank you, Michael, for organizing this. My career in pathology is maybe a little bit different. I was born and raised in Yugoslavia, now Republic of Serbia, where I finished my medical school and also pathology training. After that, I came to the United States, where I enrolled in pathology residency training here in Mount Sinai Hospital in New York City, after which I entered into forensic field, finished forensic training here in New York City, as well as cardiopathology and neuropathology forensic training. I'm fascinated by autopsies. I think they're very important, especially for me today as a forensic pathologist. And I'm very, very happy that I'm here to support the importance of autopsy in education. Thank you.
Thank you. Michael?
I suppose I'm the outlier in this group. I do not currently teach actively except to the oncology residents at Memorial Sloan Kettering and to the residents at Weill Cornell. Most of my other teaching is done outside. I'm sort of at the tail end of my career. There was a time when I had many, many hours of medical school contact. And over the years, I've sort of watched the evolution of pathology from what I started, which largely an autopsy-based education, transitioning into surgical pathology, which is what I've done with most of my life, to an area where it's now, I perceive, fairly difficult for sufficient numbers of autopsies to successfully train residents in the way that I was trained. I did my residency at NYU Bellevue Medical Center, and I did it at a time when we were doing upwards of 900 autopsies a year, which was a fairly large number for the number of residents we had. So I had very intensive autopsy training. My area of interest eventually led me to orthopedic pathology. And in orthopedic pathology, of course, one has to correlate clinical imaging, which also has changed over the years, with what you see in patient biopsies. And I think that's a very logical transition from autopsy, where you got to see the patient as a whole, where you got to see the anatomy, the pathophysiology, and all of the interrelationships. And I believe that without the intensive autopsy training, what I do now would be impossible, even though I don't really do autopsies now. I think it's still one of the most valuable things possible.
So from your individual perspectives then, what role does autopsy currently play in your work, in pathology in general, and how has that changed since the start of your career? Anyone can start with this one.
Well, I think autopsy plays a very important part in my work, as I mentioned, with my interest in cardiovascular disease. And we have used the autopsy to very much inform and help educate surgeons and cardiologists about the nuances of of the natural history and the treatment effects in their patients. So I also use the autopsy as a basis for research work. And I was very involved in keeping our autopsy service going in the early days of COVID. And we published one of the first papers from the United States describing the detailed pathology of this disease, which I think in turn has influenced the development of better treatment for the condition.
Thank you.
If it's okay, I'll jump in here briefly. I'll leave it to Dr. Marks, I believe, to talk about forensic pathology and the role of autopsy. I defer to her expertise and practice. Dr. Klein's comment about performing 900 autopsies. Yes, I think the numbers, it's obvious, the numbers have dropped to numbers that are not that anymore. I personally, I've been in practice 10 years. I benefited from having teachers that were passionate about autopsy pathology, and I too am passionate about autopsy pathology. It is my passion in medicine. I don't expect that to be everybody's passion, and I don't think that everybody can be a specialist in autopsy pathology, especially with the relatively limited training that we see now, training opportunities, not only in numbers, but pathologists who know what they're doing to teach autopsy. So I struggle with how we move forward. I think autopsy always has a place in medicine and pathology, but I also think we need to rethink how we train people in pathology. For example, I don't think every pathology resident needs to perform X number of autopsies. I think perhaps there can be room for a separate training track where we figure out how to identify those that are interested in postmortem care, either hospital and or forensic pathology. And maybe they may have a specialized training pathway. So I think I hope one of the things we can talk about is we all, I think, understand the importance of autopsy. I don't think every pathologist needs to be a specialist in autopsy. I think everyone should be exposed, and I don't know the best way to do that, but like we have rotations in breast and gyne and bone and soft tissue. I think it plays a role in training general pathologists. Dr. Klein's comment about correlating clinical pathologic correlation. I think that's very important, and autopsy definitely highlights that. So I kind of am struggling with how do we move forward to identify those and foster those who have a passion in autopsy pathology, because we always need to have those members among our community, but at the same time, not necessarily make it forced upon everybody, because I think that's where some of the negative perceptions can arise. So that's kind of more of a question, I suppose, but that's kind of where I see us right now with autopsy pathology. It's
well, I think the numbers are not so much as important as I think autopsy plays a critical role in getting residents to learn how to assimilate large amounts of information and to think critically. And my own experience with residents coming along these days is that they really need that type of experience. And as professors, it's our job to try to instill in them the abilities to do what I just said and to hone their skills in clinical pathologic correlation.
So if you don't mind, I will answer the question. So I may bring a little different perspective to this table, just because I was trained in a different country and maybe trained a little more traditionally. And I obviously do forensic pathology for a living, and I'm fascinated, and I really truly love autopsies. And I think their value in determining cause of that, in having quality insurance for hospitals, public health, education is really there in every aspect. When I say I'm going to bring a different perspective, I just want to state that during my medical education, in my medical school, pathology was emphasized as a very important part, and you really cannot move forward to clinical any kind of clinical exposure until you are proficient in pathology. And that included introduction and exposure to autopsy as well. So I remember as a medical student at that time being introduced to an autopsy, and it wasn't comfortable in the beginning, but I actually early on discovered I'm fascinated by human body, by anatomy, by disease processes, by organs in general. And that, even early on while I was in medical school, gave me enough exposure to understand what pathology is, and then pushed me later on into pathology in my home country, and then especially once I moved and transitioned to the United States. With working with residents here, not just residents, but medical students as well, I'm recognizing that there's just not a lot of exposure to pathology at all, not a lot of exposure to autopsy. Very often medical students kind of just have maybe a semester or a rotation, elective rotation in pathology, and they don't understand how important it is. They don't see autopsies. They come to our rotation here in Office of Chief Medical Examiner in a very, not expecting anything. And I very often try to change that. I'm the one here in our office who will engage them, who will talk to them, who will try to explain to them why an autopsy is being done, to link, important pieces of the puzzle, to identify the cause of that, to work with them. And what I can tell you is from my experience working with these young people who are eventually going to go in different clinical parts of medicine, they do become engaged, they do become fascinated, they do raise their curiosity about autopsy, about pathology. And I think probably, the way we can solve this would be to go back to medical schools and to expose people and see who is interested in that, who is not. I agree with Dr. Williamson that nobody should be pushed into this if you don't like it. But I think you need to have a big exposure to this and knowledge and understanding how important this is for the future clinical practice.
Well, I think that what's going on in contemporary undergraduate medical education in the United States has goals to meet the creation of so-called contemporary doctors for the current scene, but I think there are serious deficiencies, including a lack of sufficient exposure to basic pathology and pathophysiology. And I am concerned about the future of the graduates that we're producing these days.
I agree with Dr. Buja. I think that some of the fault of that, at least in pathology training, lies with pathology departments themselves. I trained in a very traditional pathology environment. Our course was 8 or 9 months. In the beginning, we saw 2 or 3 autopsies a week, mandatorily, every medical student, which, you know, when I think about how one would need to schedule autopsies in order to do that, and the numbers we have today, it's a staggering feat that they could do that. I went to Temple University, by the way, for undergraduate. We spent several hours a day, a few times a week, just in microscopy. We had traditional crock cases where autopsy organs were stored in buckets. And it was our responsibility to go through those and figure out what was wrong and, if possible, causes of death. And at the end, our examination wasn't just a written examination. We had an oral examination with 2 senior professors. It was a very intense course. It was a very intense experience. But with all of that, nowhere in medical school did anyone ever tell you that pathology was a viable thing to do for the rest of your life. The viable things to do for the rest of your life for everyone was internal medicine or surgery or places where you saw active, alive patients all the time. All the glory was there. It was as even a pathologist's responsibility seemed to be either doing autopsies or doing teaching of medical students. Maybe research. We didn't get exposed to very much of that either. So pathology as a viable interactive specialty was never pushed by pathology departments, even when there were traditional pathology courses. It was as if they didn't themselves know their place in medicine. And that has only gotten worse as pathology courses have become interdisciplinary and integrated, and pathologists pushed further and further into the background. It's very difficult to get someone interested in a career in a specialty where they don't know that there is a viable specialty. I think I've probably gone a little bit off track, but that's my opinion. And I think we need to push back. And the problem with pushing back is most of the people that want to push back are sort of in my generation or maybe a little older. Not a lot of people trained now recognize this. We can do things much better if we go to all digital pathology. Okay, digital pathology is fine. It has its place. I think the artificial intelligence software that's going to go along with it in the future is going to be able to do great things. However, in my experience, I've seen a lot of people that push digital pathology that don't know how to look through a microscope themselves, okay? And you really have to be able to do that before you translate that into another medium. That's particularly true in the specialty field that I practiced, where I need to do polarized microscopy on 80 or 85% of my specimens. I can't necessarily do that with digital. And where there are time constraints, where there's a turnover requirements necessary. And of course, the digital pathology adds to that because one has to generate the slides before one can scan them. Anyway, I think I've said too much of my piece for now.
Well, there's an old saying that all progress requires change. Not all change is progress.
Correct.
Yeah, I think, I always think of laparoscopic surgery and what the surgeons kind of had to encounter when that wave of the 80s and 90s kind of washed through as the video gamers became the surgeons. And you still have to be able to convert to an open procedure. So I like that, Dr. Klein, your description of I think the technology is good, but like any technology, like the stuff we have in our cars now that helps us drive, there always needs to be a driver in the seat that knows what to do if to bring it all together to make it work safely and effectively. So I think that is a challenge to pathologists. I think it highlights a problem that kind of ties in what we're all talking about, time and exposure. Medical schools now crammed with more and more molecular, and as we all know, the medical knowledge changes every day. Pathology as a specialty is increasing by leaps and bounds every day. And we're still only 4 years of medical school and 4 years of APCD, anatomic clinical pathology training. So I think it's just calculus why we're losing things around the fringe, like cadaver dissection and gross anatomy, looking through a microscope as a first year, attending autopsies. We just don't have enough time. And so one of my solutions, I think, that we're starting to see that I support is this idea of, I guess, in the terms of autopsy, regionalization. So we should have centers, I think, like we have centers for bone and soft tissue pathology, hospital for special surgery. MSK is the oncology specialty hospital. I think we need to advocate for and support and develop centers of autopsy excellence, aside from the forensic pathology realm, in the hospital setting, in the private realm. Autopsy pathologists who run and manage these, who are enthusiastic about the subject, who teach, who maybe all the pathology residents would rotate through these centers of excellence for exposure. But I think you can do a lot more good with a few people doing something they're passionate about than with many doing it because they have to. And I think that's true in anything that you're talking about, educating young learners. And I agree, those same pathologists in these centers training tomorrow's pathologists could also be more involved in medical school curricula. And being a face on, hey, you can become an autopsy pathologist, you can be a researcher, you can be an educator, and you can come spend time with me in my practice where I do mostly autopsy pathology and see how we interact with families, how we interact with clinicians, how we work with radiologists, how we are a member of this team that you may not be aware of. I think also undermining this, just my last point, pathology itself is probably the biggest enemy of autopsy. Look at the article which brought us all together, the opinion piece about pathologists' perceptions of the autopsy. As recently as last month, I had current residents in a program here in New York State tell me that they are persecuted essentially for wanting to go into forensics because it's a waste of their skill and ability, and we don't need more autopsy pathologists, we need more surgical pathologists. This mentality is pervasive and it's continuous, and we need to do something about that within our own profession before we look to external causes to fix.
Well, I think there is a literature about various versions of regional autopsy centers. I think there are a lot of logistics involved in bringing that off, but it's certainly something to consider. And I also think that we need to be proactive with organizations like the Association of Pathology Chairs, where Michael Klein's point about pathology departments, we need to get to the leadership of the departments to get their attention about the importance of autopsy and the importance of education for both medical students and critical thinking for pathology residents.
So to your point then about perception and awareness, how do you and your colleagues in your organizations, how do you approach fighting misconceptions and stereotypes about either autopsy or about pathology as a whole? And again, that's
Well,
for everyone.
I try to live according to the principles that we've just been articulating, and I point out to people the importance of autopsy when this comes up. And also, I believe the future of pathology is to be proactively involved as an expert consultant, So I've gone out of my way to make sure I'm in front and center before the heart failure doctors, before our cardiac surgeons, and take cases from the autopsy room and present them to them and show them how we're addressing clinical issues of importance to them. So I take a very proactive approach.
I do agree with that. I have to say that in my forensic setting here where I work, we do have a lot of rotating medical students and residents that come along, and I oftentimes try to talk to them and ask them what they think about pathology and autopsy in general, and just in those first interactions with them before I even go to the autopsy room, I can have a sense who is very negative and has, it's really there just to kind of get that signature on the paper and leave. And, I really try to engage them, to talk to them, to explain to them on a case-by-case basis that we do. And that's how I try to change their opinion, their negativity on pathology and autopsy in general. I also just want to go back and touch something that I think Dr. Williamson mentioned about the pathology training and professors and doctors. I know that there's a lot of programs in United States, pathology residency program, they really don't have good autopsy services. They don't have autopsy trained pathologists who have the knowledge, who have the passion to, transfer this on residents. A lot of times you have excellent surgical pathologists who are doing their jobs, and then you have an autopsy that comes along, and it's a very big push by them, and that gets passed on to the medical residents. So I think that's also a huge problem if you don't have a autopsy service in a smaller community hospital.
Yeah, well, that's the downside to the regional center concept, as to how to make it real for people at the different hospitals, I think.
I think an answer to that, though, like we have some places don't have renal pathology or pediatric pathology. I had to rotate for both of those out of my residency. So I think that's a valid point, but I think we already have an existing framework for allowing residents to rotate through outside institutions, such as a regional autopsy center, to be exposed to that specialty by people that passionately practice it, and that can be worked out. But I agree that is a challenge to get that up and running.
We've all heard the story or the joke many times about how the internist knows everything but does nothing, and the surgeon knows nothing but does everything, and the pathologist knows everything and does everything but a little bit too late. Mm-hmm. Whenever I hear that story, or whenever someone starts talking about the value of autopsy or the lack of value of autopsy, how we know everything from imaging, I won't tell them any of my current experiences, which demonstrate to me that imaging is not everything, that anatomy is sometimes more important. But I'll tell them a story that happened to me during my residency. And in my second year of residency, I had to do an autopsy on a 15-year-old who died of what was thought to be acute fulminant hepatitis. I remember it vividly because I remember that my wife was almost 6 months pregnant at the time. I did not want to walk into that room because I was afraid I would somehow get that virus and transmit it to her. But it was my turn. I couldn't escape it. So I did this autopsy, and I noticed two things about the individual. One was that he was very tall and thin, had a very strange build. Secondly, that he had a female pubic hair distribution, which would have been funny for a 15-year-old male. And he had been totally well, except for 2 weeks before, when all of a sudden he turned yellow, completely decompensated, and died. And the only reason that an autopsy could even be obtained on this individual was because the surgeon who was taking care of trying to get him perfused with a baboon liver, which NYU had a colony of baboons on Roosevelt Island. They found one that had the same blood type as him, and they were going to use that liver to perfuse him until he got over the acute event. At any rate, the surgeon had a great rapport with the parents. The parents were obviously aggrieved. Their 15-year-old had died, and just 2 weeks after being completely well. And they agreed because they had this rapport with the surgeons. And the surgeon's logic was that while we can't save your son, it's entirely possible that something found in this post-mortem examination might spare some other parent's grief. Okay, so I was only allowed to make a small incision and take biopsies of organs. Through that small incision, we were able to see that the liver was not a hepatitis liver. It was a cirrhotic liver, a metabolic cirrhotic liver with lots and lots and lots of small little nodules and dense fibrosis. And it's obvious that in someone that age, the only explanation conceivably was a systemic metabolic disease. And it turned out, after analyzing the tissues and the blood that I took at that autopsy, that this child had Wilson's disease, okay? And that was very important because it turns out that these parents had a 9-year-old girl who then had her first examination for liver enzymes, which she hadn't had before. And her transaminases were in the 2,500 range. It was obvious that there was something wrong with her liver too. And it turns out that she also had Wilson's disease, but it was caught at an early enough stage that she could have penicillamine chelating therapy. And that woman is in her 50s now and has a family, right? And I assume if she has kids, they all are carriers of the Wilson's gene, but they don't have Wilson's disease. None of that would have been possible without that autopsy. And that story alone, if that doesn't convince you that autopsies are important, I don't know what will.
That's a great story.
I think the problem we have to counter against that, I totally acknowledge that those cases, especially as a pediatric pathologist, I think what was raised in that recent opinion piece, and in general, I think we know this from some of our younger colleagues and residents, is you have to do 500 cases that don't have that exciting ending to get to that one. So it's the number needed to treat, or if you will, the number needed to perform. And I think that's what we struggle with is, again, those cases, I think anybody in medicine should be able to hopefully recognize the amazing tragedy in that story and the benefit that comes to those that are benefit from that knowledge, the living family members. I think though, having those cases, if you're lucky enough to have one, I think that should imprint on you as wow, this is important. I think what we have to figure out too, though, is what happens to the people that see the hypertensive heart disease maybe causing an arrhythmia or atherosclerosis causing an MI, the bread and butter, if you will. I think if those can be taught and you can still have that discussion, and that's where expertise of autopsy pathology comes in, Dr. Buja's cardiovascular expertise. Is there a predisposition to atherosclerosis in this family? You know, we've all had probably 29-year-olds drop dead of an MI, but due to ruptured plaque. But then you have to ask yourself, well, why is this 29-year-old having this ruptured plaque? And so we get into this discussion about Wilson's disease is a wonderful example of that. But with trained practitioners of autopsy pathology and clinical engagement, you can start to have discussions with the seemingly mundane things. Even MIs can become important for family members, and those discussions that arise in the family meetings. I think that's also an element that we can continue to develop as autopsy experts. And I know forensic pathologists do this regularly in their jobs. It's that ability to not just have Wilson's disease, but draw out the important medicine from many different types of cases. And that's where expertise is needed.
Well, those are all good points. The argument about, well, you do 500 routine cases before you find something dramatic, coupled with how great imaging is, is belied by the fact that study after study after study continues to show significant numbers of misdiagnoses of significance brought out by the autopsy. And that's not something that clinical medicine wants to hear, but that's what's been borne out in the literature. The other point, I think, is that there's several, I would describe autopsies as categories of one in which you have a anatomic smoking gun. You don't need a microscope. You have a ruptured thoracic aortic aneurysm with cardiac tamponade. But then you have other cases where it's not at all clear from the gross that you need microscopic, and often there's not an obvious immediate anatomic cause of death. And I think that turns off surgeons and clinicians who think that always there has to be that. But sometimes we as pathologists are not looking just at anatomy, but we have to know about physiology and pathophysiology. And when the case of the heart, the substrate may be there for an arrhythmia, which obviously doesn't have an anatomic immediate proof. So we get into those complexities.
I agree with everything that's said, but I also have to say that a lot of times, I mean, I do this every day. I do autopsies every day. And even though you don't have a smoking gun, sometimes at the time of autopsy is a cause of that. But there are batteries of things that we can do here, especially in the setting of forensic pathology, including histology, including toxicology, including for in New York City office, we have a huge molecular genetics lab where we can test for a lot of things. So I will just give you examples. If you don't know what the cause of that is at the time of autopsy, and you see on histology or vitreous sample that it's a diabetic ketoacidosis, you have diagnosis. It's just not at that time, maybe a few weeks later. If you don't have anything on autopsy and you look at the histology, there's some irregularities, and you send out for molecular genetic testing and you get a cardiac panel pathological variant mutation, channelopathy, something, then you have, you know, a cause of that. So we just kind of have to use all our, you know, different ways of testing that come with this job. Autopsy in forensic setting is just kind of the first step you take. Besides all these other additional testing that we can do in order to understand what, how, and why somebody passed away when it comes to cause of death.
So to your point then, with the new techniques and technologies that have arisen over the past few years, how has the approach to post-mortem examination, including and beyond autopsy, changed?
I just will quickly add on to just answer that question, what Dr. Marks said. I think one of the shortcomings we as pathologists are experiencing now is we don't advertise all of the cool stuff we do. Even Dr. Klein's Wilson's case, that took a lot of detailed histology and analysis to come to that answer. We still are doing that today with new tools, molecular screens for channelopathies, toxicology testing. The problem, I think, remains that a lot of people from Hollywood and TV and medical students who never see a real autopsy, they just see a pathologist at the bedside, if you will, of a corpse, dissecting that corpse, looking at the organs, and then leaving for the day. They don't see the 3-month follow-up in which we bring in all these interesting tools that they're seeing in other specialties, molecular and oncology, toxicology in the chemical lab. So I think one thing we can do, there are many new technologies now. There's imaging modalities. There's toxicology testing now, the new fentanyl derivatives. That's an ever expanding arena. The genetic profiles that you can run for epilepsy and sudden cardiac death. People don't know that we use those tools too. Again, they just see us with a dead body. So I think we need to advertise, if you will, and show through our practice. We're not just in the morgue dissecting a body, although that's the important substrate on which everything else is built. That's not where we end the story. And I think we need to do a better job at showing that to bring in all these wonderful technologies we do have today at our disposal.
Well, Dr. Williamson and Hooper's book on autopsy, the 21st century, has two very good chapters on the rapid research autopsy. And that is an approach that can be set up at different institutions to rapidly obtain tissues where the nucleic acids can be preserved for a genetic testing. Also, the ability that's coming into play with next-gen sequencing of being able to have probes that will work on formalin-fixed paraffin-embedded tissues is opening up another whole arena of capabilities for us. So from those points of view, it's very exciting. And the other point is, going back to COVID, this long COVID syndrome is a mystery. And I'm very pleased that the NIH, in their billion-dollar initiative, is including a component for autopsy and biobanking of brains and other tissues from patients who die with a history of this condition. So at the level of the NIH, the role of the autopsy in contributing to elucidating new and mysterious diseases is being recognized.
So then, from the perspective of sort of a medical student or a pathology trainee, when you have them observe or perform an autopsy, what key things do you want them to learn? And that's a question for everyone again.
Okay, I'll start because I really do work with residents at the time of autopsy pretty much on a daily basis. My first question for them is what is the field of medicine they're interested at and where they're gonna focus their careers. And you know, a lot of times it's obviously clinical medicine, cardiology, internal medicine, emergency medicine, pediatrics. And then we come to the case, and very often I just want them to identify normal organs, to tell me what they're seeing. Are they seeing a normal looking organ? What else do they see? And I get surprised when I understand that, for example, they are seeing a liver, but they do not see this is a steatotic liver or a cirrhotic liver, and it's a person who is ultimately going to go into internal medicine and treat somebody who has a liver problem. Or if you have somebody who's going to go into cardiology and we're doing an autopsy, looking into the aorta or heart vessels, examining atherosclerosis of the aorta and severity of it, and they don't understand what they're seeing is actually diffusely calcified and ulcerated aorta. So I think, you know, as a student, if you have that, idea that coming into an autopsy room, you can just benefit from seeing the organs, seeing disease processes, even just focus on essentially those diseases that you're going to be treating in the future is beneficial for them. And I do think that at the very end, once we are done with the autopsy, they understand that they just benefited from seeing one.
Those are very good points. I'll take it from the perspective of a nascent pathology resident. What I try to instill upon them is correlation with the clinical history, if at all possible, contact with the clinicians to ask them what issues are of importance to them, and therefore do not go into the autopsy just a rush of something to get done that day. But what are the critical questions that need to be answered by the autopsy? And to have a directed mindset to performing the examination to get at those critical questions. That's the approach that I try to instill in the residents.
And I just add to that, I agree with both of those discussions are wonderful. I always emphasize that autopsy is about the living, be it a medical student, a clinician, our residents. What we're doing here in the morgue, in the autopsy suite, is for the benefit of the living. It's for the benefit of the care that they will be delivering or are delivering as clinicians. It's for the benefit of that family. Some of our residents, for example, have a tough time doing their first few fetuses, especially those that may be starting a family of their own. And I always emphasize with them that what we learn from that fetus is about that unborn sibling, that child's future sibling that's yet to be born. How are mom and dad going to benefit with their obstetrician in a subsequent pregnancy to allow that one to succeed? And I found that to be very helpful, especially with the pediatric work we do. Make it about the living. In forensics, pediatric forensics, which fortunately is not a specialty that one can practice by itself. But when I encounter those cases, it's always about that tragedy. What can we learn from it to protect the siblings in that family, the next door neighbor, or exonerate the parents? Everything we do with a dead body ultimately is about the living. And I think we need to emphasize that more as autopsy pathologists. And I do think pathologists in general need to recognize that. And again, if you don't have anything nice to say about the autopsy, don't say anything at all. But hopefully all pathologists with quality exposure to autopsy can at least recognize that it's not just about smelly dead people decomposing in the morgue. And I think that's what this latest piece kind of set off. So I think I always try and bring it back to the living. It's the practice of medicine. It's legally defined as that in a majority of the United States. And we are physicians like any other typical white coat internal medicine doctor or surgeon. And I think we need to emphasize that in our daily actions. And when we interact with learners of all levels, but particularly the younger ones, demonstrate that we are, look at us, this is our practice of medicine, and that's incredible. And we encourage you to explore it and realize that you're helping the living. It's not just about the dead.
Well, that's well said, but your comment has is a general principle. If you can't say something nice about something or somebody, don't say anything at all.
So do you think then that the perception of autopsy has changed, particularly since the onset of the pandemic and the use of postmortem examination to learn most of what we now know about COVID-19?
I think we've made a strong case. How well it's appreciated or perceived, I think it's probably variable, but I mean, I contend that without the autopsy work, we wouldn't have the improved therapies, including anticoagulation, rapid anticoagulation for seriously ill COVID patients.
Yeah, I think the COVID-19 pandemic reinvigorated the role of autopsy, but it's up to us to carry the torch. And I use that experience to train the future generation of pathologists. And, we're struggling with that admittedly, but as I tell all my residents, you're going to answer the next bell when the next pandemic comes, and it will come. This is our 6th large scale viral pathology interaction this century, starting with West Nile in 2000. So the next group of pathologists needs to be ready to uncover and decipher the next viral pathogen or whatever that pathogen is. And we need to have a cadre of qualified autopsy pathologists to answer the bell when it rings again, because it will. And that's the biggest thing that scares me about not having a trained corps of autopsy pathologists in the world in various countries ready to deploy. If you don't know what you're doing in the autopsy suite, you're going to harm yourself or others. You're going to miss subtle clues, and you're not going to serve medicine and the population, the public health. And that's our biggest responsibility, I think, as autopsy pathologists in the hospital and the medical examiner's office, is protecting public health when a new disease emerges.
So for all of you then, what advice do you have for new or aspiring pathology professionals who are interested in a career that involves autopsy?
Something that's going to be pursued in, at least in the United States, in the academic setting and in the forensic setting. part of the problem is the economics. The autopsy is an orphan in terms of the current, at least U.S. Health economic system. So that's why private practice is not interested. But so you have to design a career in which you have a scholarly focus that would join with the autopsy, and making sure you have a plan to integrate your interest in autopsy with scholarly pursuits, usually in a subspecialty area of interest.
I think it would help immensely if some of the regulating agencies woke up
Yes.
and recognized the importance of autopsies. My perception is that from the time the Joint Commission of Accreditation of Hospitals and Healthcare Groups basically dropped their autopsy requirement, that was the major thing that pulled the plug on the numbers of autopsies, because there was no longer any pressure to obtain them when otherwise they would have been obtained. And in that same vein, I think that some of the paying agencies, like the Centers for Medicare and Medicaid, should also mandate that. And as part of that, they should reimburse some of that, because this is too important to just go away because it costs too much and no one wants to pay for it. I think that's a huge mistake. There are a lot of huge mistakes in medicine, but that's an unseen, but one that's right out there, and nobody wants to acknowledge that.
That's what I was alluding to. Yes.
Yeah, and I would make a plea to my my colleagues that do autopsies for a living. Okay, one of the reasons that I went into musculoskeletal pathology is that there was an incredible deficiency, and there still is an incredible deficiency in the examination of musculoskeletal diseases at the time of autopsy. You know, I can ask all of you how many times during the time you practice adult autopsies do you sample bone when it isn't the vertebral column, or maybe the occasional piece of the skull when you take off a skull cap at the time of a brain examination. There are many times when I get cases referred to me where there are autopsy findings of bone, and can I explain what's going on, and can I correlate that with what's going on in the patient? And yet the section was taken from a rib or a skull or a spine, and the patient didn't have a metabolic disease, and there's nothing to look at. Okay, we don't examine joints at the time of autopsy. We don't examine bones other than the things that are generally available when we make the the Y incisions. I think that sort of to compensate for that, and one of the things we do in my specialty is we spend a lot of time on imaging, because that's the closest we can come to having autopsy findings to correlate. And that's told me that we're not doing as well with imaging as we think we are, particularly with the advent of MRI, where I see very regularly in my own institution reports of, there is bone-on-bone contact in a joint and so on and so on. And when you actually get the joint resected, there isn't even any erosion of the cartilage. So there's something reversible molecularly that's going on that makes water disappear from the tissue. And the radiologist who hasn't seen the plain film, but just the MR, says, oh, there's no cartilage there. Not true. These are very important things. And I think we should have more than just the things we find surgically.
I think that's where clinical pathologic correlation comes in. Dr. Buja alluded to that. I always start every autopsy with a problem list, just like we do as clinicians. We have our problem list. I practice that in the autopsy suite. For example, people that have muscular complaints, they can't walk upstairs in the last couple of years of life, we'll sample the quadriceps muscle and the nerve, just like you do in a living patient. I always try and emphasize what we do in living people should be done in the autopsy suite as well for diagnostic workup, but that does necessitate a command of autopsy pathology and the art of its practice, wherein one correlates, gets a clinical history, talks to the clinician, knows those questions. Because if you don't know you need to look for to go after it, you won't do that. So I agree we can get better at clinical pathologic correlation before doing the procedure so that we can answer all those questions.
Thank you. Jelena, do you have any career advice for aspiring autopsy pathologists?
Yes, I would be happy to have them over. I'm very passionate about autopsy. I love working with students and medical residents if they are particularly have an interest in autopsy. I try to take one step more to train them to do full evisceration if they're interested in that. And I actually did have a couple of pathology residents who were undecided, came in early because they had interest in forensics, and I think they benefited. So I'm always open to, have young people reach out. And that's always my advice to all of them. If you have questions, as a group of forensic pathologists, medical examiners, we are usually very open and communicating with young people, especially dragging people and to our field. So I would always advise them to reach out to get more information.
And I would just add to that, I advise people to talk to those who know what they're doing. Again, unfortunately, within the realm of pathology, you'll have negative to neutral to predominantly ill-informed opinions on the autopsy. So students and learners and people who may be exploring postmortem care should really talk to seasoned practitioners that know what they're doing and do it on a daily basis. Medical examiners, hospital autopsy pathologists, make an informed decision. Don't let others' bias and frankly ignorance shape your opinion of the specialty.
Thank you. We're short on time, so one last question and we'll go in order. What one key message would you like other pathologists and lab medicine professionals to take away from this discussion? So Alex, if we can start with you.
I would emphasize that autopsy pathology, like any other specialty in pathology, is a specialty, and it demands experience and, most importantly, I think, a passion to do it well. And I would just emphasize, if you don't have anything nice to say about autopsy pathology, don't say anything at all, because I think that's doing a lot of damage. Refer an inquiring resident or medical student to someone who actually practices autopsy pathology to help answer their questions and guide them. Do not have a negative opinion about any specialty in pathology. We've done too much infighting among ourselves. I think that needs to stop, and that's all in our court.
Thank you.
I agree to that. And I just want to also say that I do know a lot of pathologists, surgical pathologists. They're excellent pathologists, experts in their field, but they don't have good autopsy training. They don't themselves know how to perform an autopsy, but they do have negative opinions of autopsy procedures. So I would advise them to find somebody who actually can do it and can show them how it's done, so that hopefully they can change that for the future of their own residents and their training programs.
I would just say that pathologists need to recognize that autopsy is the ultimate quality control measure in medicine, and needs to be, and the practitioners of the autopsy need to be respected as valued colleagues in the department.
And my not being an autopsy pathologist doesn't mean that I won't advocate for all of this. And I like to teach by analogy. And my analogy is this: the body is the Tower of Babel. The cardiovascular system is the English alphabet. The digestive system is the Cyrillic alphabet. The musculoskeletal system is the Hebrew alphabet, and we can go on and on and on with systems. When you take a small biopsy of any of those systems, it's your job as a pathologist not simply to recognize that the letter comes from a particular alphabet, but what the relationships of the letters are in making the words, and how, if those letters are large or small or fragmented, what that has to do with the disease. And you can't tell any of that until you know how it all fits together. And that is the importance of autopsy. You can't be a good any other kind of pathologist, at least in my opinion, unless you've done your complement of autopsies and gotten to understand all of those interrelationships and how they alter over time and disease.
That's great. Thank you so much. Thanks so much to all of you for engaging in this conversation. Although autopsy is the subject of much debate and, as we know, many misconceptions, its value is also clear in both education and practice. So I hope this discussion has been informative, not only for those within pathology and laboratory medicine, but also for anyone who is curious about the discipline. And I'm afraid that's all we have time for today. So from everyone at the Pathologist, thank you for listening and stay well.
Thank you very much.
Thank you.
Thank you.